Much. Yes, Rose, it will be. Welcome. So we are recording this today, and thanks everyone for joining us. First of all, I'd like to acknowledge the traditional owners of the country in which we meet today, the Yagara and Turrbal people, and I'd like to pay my respect to the leaders, past, present and emerging. So today, so my name's Belinda Mayer. I am the Strategic Midwifery Research and Policy Officer for the QNMU. So basically anything professional comes my way. I have been a home birth midwife for a long time, on and off, and I've also, I do a range of other things. So it's great that we've had so much interest in this webinar today, which is very exciting. I'm just going to share my screen now. Why is that doing that? Ebony, what screen can you see?
I can see your PowerPoint. It's perfect.
Oh, good. Excellent. So, which is weird because it's come up on the other screen, but that's okay. So I apologise if I'm looking away from everyone when I'm doing it. So today we're going to be discussing management of postpartum hemorrhage for midwives in smaller areas. So whether it's home birth or a small rural area where you don't have that big button where everyone comes running in and everyone has a role to play. We are recording this today so that anyone can look at it. Of course, it does give you CPD points, and I'm happy for anyone to ask questions at any time. Either type it into the chat or just ask me, or put your hand up. And Ebony, the wonderful Ebony, is supporting me here today in doing this presentation. So I will start. Okay, so as I said, this is for those of you that don't have that big red button to press, and that's what most of obstetric emergency courses are around that. So this is slightly different. And look, I can see by the number of people here that there are a range of different midwives with different backgrounds and experiences. So I'm more than happy. I'm not their be-all and expert by any means in this. So if anyone wants to add their own stories or their own perspectives, you're more than welcome at any point. I can't see necessarily once you start sharing the screen. It's a bit more awkward, so bear with me. So we'll be talking about the definition of postpartum hemorrhage, prevention or identifying risks, management of third stage, it's very, very brief, the causes of PPH, managing, and then post-PPH care. So first of all, I know everyone's really, especially in very small units or home birth, it's quite scary, the idea of, or the experience of a PPH. But this slide is just to show that the actual maternal deaths from PPH is quite low. So they do get managed. They are scary, but you can manage them, and women can do very well. A lot of what we're talking about when we're talking home birth or small rural areas is that you're going to have women in your area that you're birthing that's not necessarily going to be within the more vulnerable or risk factors, because you wouldn't be birthing them at home or in a small facility. They'll be birthing in a high facility. So primary PPH is within the first 24 hours, and it's around 500 to 600 mils. That can change state by state, but so 1 in 5 women between 2009 and 2013 experienced a primary hemorrhage, and 1 in 71 experienced severe primary postpartum hemorrhage. So that severe is around 2 litres. Women who had, so the research shows women who have an unassisted vaginal birth have the lowest incidence of primary postpartum hemorrhage. So again, if you're more likely, especially in a home birth or in a very small rural facility, to have a normal birth, which is the point. And so therefore the risk of primary postpartum hemorrhage is very low. Secondary is after 24 hours and up to 6 to 12 weeks, depending on the definition. And again, that changes state by state, and it's most common within the first 2 weeks. So preparing. So you're in a small rural facility or a home birth, particularly around home birth, is you make sure that you're prepared. It's the same for neonatal resuscitation. You have everything prepared and ready. That doesn't mean you're drawing up drugs or anything like that, but you know exactly where it is and how to put your hands on them in an emergency as soon as you need it. So you would make sure that you carry that, you understand the use of the drugs or whatever drug protocol you will use, whether that's your own private practice or within your health service, small rural facility, because that varies dramatically. Knowing how to manage PPH obviously is really important. Having your own process and steps, and being aware of the manoeuvres that you need to use, and knowing who you can call and where you can transfer to is really important. So if you're in a rural facility, if you needed help, who would you call, and where would you be looking to transfer that woman to? And it's the same for home birth. So you would call home birth. Obviously, you would call 000 because you would be getting the ambulance to help you transfer the woman. But where would you be transferring to? Do you have a hospital that you have a relationship with, or the ability to talk and discuss what's going on with the woman as she's being transferred, if that's what needs to happen? So those are the sort of things that are contextual and very different. So for when I was in Adelaide doing home birth, depending on where the woman was, depending on which hospital, I would contact and discuss if I needed to do a transfer. I know when I'm a bit nervous, I talk a bit fast, so I think I might be talking a bit fast. Does anyone have any questions so far? More than welcome to jump in any time. Oh, cool. So carry everything you need with you to every birth. So always have your resus equipment with you at all births. So that's your whatever you need, your cannulas, your IV fluids, the medications that you might use, catheterization equipment, the things that you might need. And when you're always prepared for it, you very rarely need to use it. But you need to have it on hand so that you don't, you haven't got it in the car, so you have to send someone out to your car to get your resus equipment. Always have that stuff ready and prepared. So risk factors for women that may, and this is not an endless list, but so various vulnerabilities, hemoglobin, past history, blood disorders, cesarean section. Now, I certainly looked after a lot of women who'd had a cesarean section that were birthing at home. So that's not necessarily something that's going to prevent you from caring for someone for a home birth. But certainly other things like a blood disorder, for example, you would probably reconsider where that woman will birth. Multiple pregnancy, prolonged labour or birth, induction. We know, the more intervention, the more complications that occur and the more emergent scenarios occur. Hypertensive disorders, and there's a range of other things. Causes, 4Ts, and arguably there's a fifth, but we all tend to talk about the 4Ts. So tone, trauma, tissue thrombin. It's going to be one of those things, and there is some research that's talking about temperatures as well. So if the woman's got an infection, for example, that she's at high risk of continuing to bleed. So a chorioamnionitis or something like that. But we talk all the time about tone, tissue, trauma, and thrombin. So tone is the most common. So the uterus just won't contract for whatever reason. That at all times, if it's boggy, that's what you're going for straight away when you're managing a PPH. Trauma, about 19%, so that's cervical, vaginal, or perineum, pelvic hematoma, and uterus. And so that the hematoma is surprisingly, a woman can have, like a I have seen it, a vulval hematoma that's got, like 400 or 500 mils of blood in it. So that is unusual, but it can happen. Tissue, so your retained products, invasive placenta, and we are seeing more and more of that with the significant increase in caesarean sections. So they're starting to see more placenta accretia, and thrombin, blood clotting disorders, inherited or acquired, including DIC. Does anyone have anything they want to ask around the 4Ts? Got a nice little picture here. I'm a very visual person. I didn't draw this. I have got the reference to it. So again, it's just a nice visual of the 4Ts. So the retained products, obviously, tone, trauma, perineal trauma, uterine rupture, cervical tear. And we'll have this. This is recorded and it'll be available to you, but you can also have, I'm happy to share the PowerPoint. So one of the key things around that we talk about all the time around postpartum hemorrhage, especially the kind of the sneaky ones, is estimation of blood loss. So we know the research shows over and over that it can be really flawed. So while we have all these different sort of posters, and I couldn't find one that showed blood loss in water birth, and I have seen one many years ago, but I couldn't find it on the web. But this gives you an indication, but your best bet is to weigh. So even if whether you're at home or in the hospital when you're changing pads or the blueies underneath or towels or whatever, is that you keep them to the side so that at some point you can weigh them if you're concerned, if there's concern around the PPH, so you have an estimation. It's a little bit like APGARs. You don't do your APGAR and then decide whether you're going to resus the baby. You resus the baby and then you go back and look at the APGAR. So the same for postpartum hemorrhage. You're going to be managing it straight away unless the woman sort of is starting to be symptomatic and there's been a hidden bleed, or maybe people have been helpful and been changing pads and no one realised that was 200 mils and that was 200 mils. And now, 40 minutes later, she's feeling really lousy and you check and it's, she's already had 600 mil loss, which can happen. Those, the sneaky ones where they're sitting up and it's the towels and everything are all behind them. So the estimation of blood loss is really, really important. And the best way, obviously, as I said, is through weighing. So just touching on water birth. So the woman can birth the placenta physiologically in the bath, obviously not if for some reason active management will occur. I know there's a lot of dispute around third stage management. So physiologic versus active, or the interventionist, and a lot of people will teach prevention of PPH through active management of third stage, but the research doesn't necessarily support that. It certainly depends on the woman, on the context of her birth, on the context of what medication's been used in a birth. So if a woman's had an induction, for example, then physiologic is probably not going to be the safest way for her because we've already messed hormonally with her. And so she probably does need to be actively managed. But if we are talking about is women birthing at home or in a small rural facility. And so they're more likely to have had a normal birth and not have had medications in birth that could affect her physiologically or hormonally with the management of third stage. Of course, it's always the woman's choice. Management, it should be an informed choice. So the key thing with physiologic third stage is to wait and don't touch. So we know that regardless of how you're going to manage third stage, that when the baby is birthed, that you and hopefully mother is holding the baby, we're waiting for the cord to stop pulsating. We know that makes a significant difference to their health and well-being long term. And it's one of those interesting things that used to be you know, back in the day, it was, you know, just us crazy hippies that, you know, thought that, you know, it was a cutesy sort of thing to do. Whereas now, of course, the research and evidence shows that it's not. It's actually physiologically a good thing to do. So regardless of how you manage it, you're waiting for the cord to stop beating. So with physiologic third stage, the key is just not to mess with it, not to mess with anything. And some of the research, so the change to active management came through many years ago now. Research around active versus physiologic, and what they did was the physiologic, they still managed as though active, so with controlled cord traction, but one they used drugs and one they didn't. So of course the physiologic one had much greater rates of PPH because you shouldn't be doing controlled contraction. But unfortunately, that's kind of really embedded in practice. That came out probably 20, 30 years ago, the Bristol trial, and it's still influencing the way people manage. The key thing is to know your skills and know what your, well, first of all, always woman consent, informed consent, and choice, and then what your skills are, what your skill set is. And work to your scope of practice and be aware of it. That is really important. Does anyone have any questions on physiologic third stage? I'm not going to go into detail about all that because everyone's midwives. They know how to manage third stage. Okay. Woman's choice tends to use syntocinon, but we're starting to see an increased use of going back to sinometron, which is very unpleasant for women. Obviously, they're bleeding, then you have to do what you have to do, but sinometron we know can make the uricot, and it can make them vomit and give them really nasty afterbirth pains and push their blood pressure up. So if they've got blood pressure issues, you would not be using it. And then controlled contraction. So this is more managed, a much more managed third stage, which can be quite uncomfortable for women. So what are you doing once the placenta's birthed around managing or observing for normal postnatal blood loss compared to someone that's bleeding significantly? So try not to interfere with the golden hour. So that first hour of just the mother and the baby and whoever else, but you know the skin to skin and the baby going to the breast as soon as possible, and all of that is really important. So at that point, it's sort of, some of it's just, you know, the context of where you're in. So when we say, you know, feel the mother's fundus, if you can feel it and you can feel it's hard, you don't have to keep feeling it, because that's going to be painful for a woman, especially if it's not her first baby. So some women might not even let you. So if you can briefly touch it, you can feel that it's hard as a rock, because we know, you know, there's a definite difference. Then that's fine. Do a set of obs if you can. All of this minimally interfering with that sort of that first golden hour, which is really important. And then you're sort of managing it from there on, depending on the context where she is. Women often, if they're on all fours, will want to turn around and lie back and hold their baby. So you know you're observing everything as you're going as well. If they're in the bath, sometimes they'll want to get out, sometimes not. So you're not rushing in and being scared of a postpartum hemorrhage. We're always happy when that baby births, the placenta births, the uterus stays nice and contracted, and you know, it's usually, for me personally, 24 hours after the birth is when I get that happy high, because it's sort of, you're still sort of making sure everything's going okay over that first 24 hours. And monitoring loss, obviously. So the different types of bleeding, and this is just Belinda Mayer talk. But you know, you've got the slow hidden ones. I think they're sometimes the ones that catch you by surprise, when the woman gets up and feels a bit dizzy, and then you realise that she's like, there's all this blood behind her. The the small gushes. So, you know, she gushes a little bit, you rub her fundus up and it goes hard, and she gushes a little bit more. Those are the sort of ones you need to keep a really close eye on, because then you're thinking, do I need to, is it time, you know, how often is this happening? How much effort am I having to do to continue to rub their fundus up? And do I need to start looking at medication management now? So is she better off having a dose of syntocinon? And of course, the rapid loss, which is really scary, where, you know, there's just sort of that heavy loss. And that's when you get in there and do your maneuvers much quicker. So it's all contextual, you know, there's no, you're sort of using your expertise, your knowledge, to decide how quickly you're going through all your steps. So, you know, obviously if she's gushing blood, you're going to be getting a catheter in and starting medication management pretty well straight away. If it's going slowly, then you know, you might be doing other things. So anytime you're worried, call for help or support. When I say other staff, so this is for people that are in a small hospital. I have taught for Krana Plus for the last few years, and we teach maternity emergencies to nurses, remote nurses. And so so for some of those nurses, there might be one nurse and in a single post, and she might be depending on the local policeman, the AMBO, whoever she can get her hands on. Hopefully, for a start, we're midwives. I'm assuming everyone's a midwife, and so we know what we're doing in the first place, or should do. And then if you're having someone birthing at home or at a small hospital facility or small health facility, and it's all planned, then again, it shouldn't be that sort of, you know, there should be some preparation and some backup support that you've already considered and worked through. I personally worked as up until 2014, I worked as a solo midwife, so I did work on my own. I didn't have a second midwife. Then, you know, all the APRA regulations and things came in, and I started working with and mentoring a wonderful midwife. So I had a second midwife. So most home birth midwives will have a second midwife. Sometimes birth goes too fast and the second midwife doesn't get there at the time, but you'll have those sort of those processes and those things in mind when you're working through how you practice. And the same for small hospitals. Chances are there'll be other people around, maybe not another midwife, but there'll be hopefully a registered nurse, an enrolled nurse. Hopefully, you know, you'll be able to get that obstetric backup through register or whoever's on call, if that's what you need. So there's a range of different things that that you might do if you're starting to get worried or feeling at any point you need that backup. So you can never call help too soon, really. And that's a bit contentious and a bit simplistic. But you certainly don't want to wait too long either. So obviously home birth, you'll be, if you're feeling that, someone will be calling 000, and that might be you, it might be your partner, it might be one of the birth support people. In Victoria, and I show Safe Care Victoria, they did do a study, and I was hoping to bring it here. They were quite happy for me to use their data and their framework in Queensland, and I just have not had the opportunity to bring it in. But they did a study where they workshopped ambulance and paramedics, and private practice midwives, and they would do scenarios in a home. So they didn't, do the scenarios in the education room or whatever. They would do scenarios together, and what they found is that just made the working relationships between paramedics and private midwives much better and much safer, because we know that I know many private practice midwives that have had a lot of problems when they've called the ambulance officers in. I've only ever had to do it once, and they were great, and they were so relieved when they realised that I was a midwife. So hopefully that's sort of changing. But again, that sort of depends on where you're working and how you can develop those relationships so that everyone works collaboratively. If the woman's in water, then you're looking at moving her safely onto dry land. And that can be, the best way is to float her on top. So don't drain the bath, because then it's going to be much harder if you can float her on top and then move her over to wherever, even if that's on the floor. And I can guarantee you, if that woman's got support people around her, they'll help get her out and get her down onto a safe, dry place very quickly. Does anyone have any questions so far? It's really tricky because I can't see anyone. I'm looking at myself and I'm looking at my PowerPoint.
No questions yet, Belinda. There's just a few comments, but we can touch base with them at the end if you want.
Okay. Yep. Thank you. So some of the signs of PPH, apart from the obvious, the blood loss is, the changes obviously in our observations, dizziness, blood pressure, restlessness and agitation, back pain. And I'm sure you all probably know, and I'm happy for you to throw in anything that you found. My midwife partner was reminded me yawning can sometimes be a sign. Obviously, loss of consciousness and vagueness. That sort of. There's other things. Pale, range of different things. I don't know if anyone else wants to throw anything in there that they've seen or experienced. Probably a lot of people on it. It's a bit intimidating to shout out, but we're all midwives. We know we can get mouthy. So checking the source of bleeding. So tear, is it a tear? So first thing you're going to do is rub up her fundus. If her fundus is firm, then you're looking at other things. So then you'll be looking, is there a tear there? Can I see where the bleeding's coming from? Sometimes you might see a little artery that's spurting and you'll get your forceps or your artery forceps or whatever you can do, or pressure. And you'll be doing that until you can either resolve it or transfer her. Tissue, you'll be checking the placenta. Is there something obvious? And it's interesting. We always say, check the placenta, but it's really, really tricky to see whether there's something missing. I mean, sometimes it can be obvious, but often it's not very obvious. And then, of course, thrombin, and that will be if it's a thrombin thing, there'll be it won't be clotting, and it'll be coming out of an IV site and things like that, and that's bad news, obviously. So if it's boggy, which is 70%, we round tone. So you've got a boggy uterus and you're needing to rub that up. And so one of the things is if she's spurting a little bit, or you just, it's getting heavy, has she peed? Does she need to pee? It's such a simple thing to do. And it can just be once she pees and empties her bladder, it settles down and the uterus contracts and stays contracted. It's really one of the key first line things that you'll be doing is getting her to pee. Now, if she can't get up to the toilet and pee, put a towel under her, do anything, obviously pan if you've got one, but trying to get her to pee is really important. Obviously, if she is bleeding really badly and you're going to jump in much quicker with whatever intervention you might do, which is putting a catheter in, getting some IVs into her, getting medication into her. So that will drive how fast you work in this context. So obviously you're going to give, and you wouldn't necessarily have IV cannulas in as a preventative thing because we're midwives. When we teach remote nurses that are not expecting women to birth with them, we do teach, you would put an IV in because they don't know anything about this woman, and they've got the rate when they are going to jump in is going to be quicker because it's more of an emergency. Just the fact that they've got someone birthing with them that wasn't expected to be birthing with them. But you'll have those things ready, and you'll be working through, depending on the help that you've got with you, what you're going to do first. So if you're rubbing up her fundus and you've got a midwife partner or a registered nurse or whatever, you'll be saying what it is you need. So I I need her to get Synto while I'm putting in the cannula, or put in a cannula, or I'm rubbing up her fundus, and someone else might be able to do something for you, like a blood pressure, or help you while you put a catheter in. So the drugs, and this varies as well. So we tend to have the step of drugs that we use, and it really depends on the situation once again. So oxytocin, you can use 2 doses of oxytocin. So you give it IM, and if you're still a little bit worried, you can give a second dose while you're getting other things ready. You might use sintimetron. You might use ergometrin, and then misoprostol is a good one, and your oxytocin infusion. So if you're starting to step through this process, as soon as you can, you're going to be getting someone to do your if they can to set up a Synto infusion. So whether that's 40 units in a litre over 4 hours, or 40 units in 500 mils, 125 mils an hour over 4 hours, you'll be getting that ready sooner rather than later if you're already starting to step through the process of these medications. And like I said, it just varies on whether you can what you have in your kit, what your hospital holds. Tranexamic acid is certainly recommended by the World Health Organization, but not everyone has access to it or knows how to use it, because you need to work within your scope of practice. And the other one is carbetocin, which some places use and some places don't. It seemed to come in for a while, and then it's not used as much. So they're the sort of things that you need to determine what are your ranges of medication that you're going to use, and how quickly you're going to jump through them to obviously manage the PPH. So at some point it's going to start working. The whole time you're rubbing her fundus, you need to continue to rub her fundus and manage her. We go through doctor's ABC. So manage her because you're going into resuscitation sort of mode now. So danger. So where is she? Is the floor slippery? I mean, it seems simplistic, but is she holding the baby? Do you need to get someone else to hold the baby for her, or put the baby somewhere safe? You're checking for response. You're sending for help. You might have access if you're on your own. So you're more than likely to have a second person with you. But if you didn't, you would be talking to someone on the phone, and they might be supporting you, especially if you're in a hospital service. If you're not an eligible midwife, I can't believe I said eligible. If you're not an endorsed midwife with an endorsement, and you don't have your own prescribing authorities, you might be being guided by whatever, but you should know what you use. And certainly in Queensland, we work under arrangements that would allow midwives to use these medications that they need to use. It'll just be a matter of what is at your hospital. So airway, breathing, if you carry oxygen, and she's symptomatic, your 2 cannulas. We always say 2 large bore cannulas if you can. Obviously the first one's really important anyway, but if you can get 2 in, because you're going to be giving her some fluids. One of the key things with replacing blood with fluids, whether it's Hartmann's, normal saline, gel fusion, whatever, is that at some point blood needs to be replaced by blood. So when they've looked at some women that have died from postpartum hemorrhage, one of the things that they find is that they didn't replace blood with blood quickly enough. And certainly you'll be able to, once you transfer the woman in, or you're in a smaller hospital, and either she's going to be transferred out, or you've got a retrieval team coming in, whatever. At some point, blood needs to be replaced with blood if it's a significant hemorrhage. And so you're stepping through your medication management as you're going through your resuscitation. So checking a fundus, doing OBS, getting help, catheter, so a urinary catheter, IV access drugs, your fluids. And then if all these things you've gone through and you've used everything in your kitty and it's still a significant bleed, and you might jump to this sooner rather than later, depending on how significant the bleed is, but then you'll be moving into bimanual compression. If you're in a health service that has, Bacary balloons and or you have access to those sort of things, then that's great. But we're talking about being in a home birth situation or a very small rural situation, and you're kind of it for a while at least. Then you'll move into bimanual compression, and it certainly can work. And I've heard of someone, one of the nurses that I taught had to do it for a woman, and she had to do that for about 6 hours, but that woman survived. It's an awful thing to have to do, but obviously if it saves a woman's life. One of the key things around all of these things, of course, is later on is the debriefing and the talking through it all, because if it's a catastrophic PPH, then you're going to have to race through things really quickly to save that woman's life. So it's those sort of things are really important. The whole time you're doing all of these things, you're dealing with a PPH, it's still dealing with the woman as a whole and the family around her. So you'll be explaining things as you go. I haven't sort of said that because I would expect that we would all be doing that, when you're talking to the woman about your concerns and what you're using, and I need to put a catheter in now because I need, that might, all these things you're doing with, you're informing the woman and hopefully, particularly if it's a woman that you've cared for in pregnancy, you've talked about different ways that you might manage certain emergencies, particularly if it's a home birth. So these are the sort of things I might do. And most women ask these questions because, people will try to scare them. Well, what if this happens at home? Or what if this happens at home? Because people don't realise that midwives do carry all these medications and all these resuscitation tools with them. So bimanual compression, so that can be done for as long as it needs to be done until you get the help and support that you need, or until it works, until all your medications have kicked in and the uterus stays contracted. So now you want to make sure that she's still pre-peeing to post, so it's all settled down, it's worked, whether you've had to transfer or not, or whether she's stable enough and it hasn't been significant bleed. Obviously, if it's a significant bleed, you'll more than likely be transferring her because she might need a blood transfusion, but you'll be checking her hemoglobin and checking at day 3 regardless, maybe even every day depending on how symptomatic she is, because we know if it's a very small woman with a low HB. So my first ever home birth, a woman that birthed at home with me, was a very, very, very slim woman. She was a vegetarian, nothing against vegetarians, but she didn't have a great diet. So her hemoglobin was about 9.9, wasn't huge, but she was a very thin woman. She ended up having a PPH with me. She and it resolved after 2 doses of the Synto, and I was getting ready for everything else because hers was just a small sort of, bursty ones. So of course it wasn't, I was worried about her because she was so small. So it was probably about 500 mils, but she was very symptomatic as compared to someone who might be a bigger woman, hemoglobin of 13 that loses 500 mils and is absolutely fine. So the context and the woman makes a big difference with, again, how you manage it and then how you manage her postnatally. So all being that you're with her, you're making sure that she continues to pee. Breastfeeding, of course, from the start, breastfeeding is really, really important. The little gushies or small sort of PPH, of course, one of your key things you're going to do at the beginning is get that baby, or try to get that baby on the breast so that it stimulates the oxytocin. Debriefing is really important, and you'll probably have to do that more than once. And I guess that's one of the great things about being a home birth midwife is you follow that woman up for ages, and you can debrief as many times as she needs to. Documentation, of course, and observations over the next few days, and then and checking her bloods to see what her hemoglobin is doing, iron, etc. So Safer Care Victoria's got a great website with it's got a lot of these things and how to manage, and they are related to home birth. So there's some good little webinars on that one if anyone ever wants to have a look. And take a deep breath, because you've managed it, and all is going to be fine. And I don't mean to say that simplistically, because it's terrifying, and 24 hours later you'll be like, oh my gosh. But it can be managed, and a majority of the time it is managed well. So that is the end for me. I'll just read through the Hillary. Yes, there absolutely needs to be a class of managing physiological third stage, because people just, they think it's just not using Synto, you know, and it's not that at all. That's what makes it unsafe. And carbetocin, that's good to know, Alison. Wanting herbal no bleed teas and homeopathics. Yep. From Christchurch, New Zealand. Goodness. Yes, I would probably start off with two injections of the 10 units of oxytocin. Well, yeah, if you've got an IV in her and you can whack an IV in her quickly, then definitely IV is always going to be better. So Rowena, there was no questions, just comments. Do you want us to read the comments?
Yes, please, if that's right. Yep. I'm just what you're answering.
Yeah, no one's had a question. They're just talking about, so Hillary said there needs to be a class on managing physiological third stage for hospital clinicians, which I absolutely agree with. Alison has said carbetocin for third stage is proven to be great, and none of the side effects, if there are risk factors, that is, which is good, interesting. Hillary said there are more women now wanting herbal no bleed teas and homeopathics, always a fine line. And Emma has said we use those prophylactically rather as a treatment, Hillary. And then Becky said, would you do 2 times 10 units of IM oxy? Not standard practice here. We usually do 1 dose or 5 of 10 units or 5 units IV, then move on to intervention. And that would make sense. That's fine. It would depend on whether we tend to say 2 doses of 10 units. But if you've got an IV, then you would do the 5 units. Or even 10, and move on to your medication that has ergot in it for sure. A great profession with me, starting my grad year next year. Thank you. Awesome, Sarah. 5 units IVs for induction and 10 units IMs. Postpartum. Edlin, I think I got that right. Remember to support the uterus abdominally when rubbing up. Remember that all supporting ligaments, blood vessels have been enlarged and stretched. It will be above the umbi while you're doing that. Thank you, Mary. Yep. That's awesome. I mean, you know, like I know a lot of women will, I found, and it's been a couple of years now since I've done home birth, but we had, and I worked with the awesome Hillary, who's still doing home birth. We found a lot of women were doing the encapsulation of the placenta, and anecdotally, they did believe that it worked really well for when they just recovering, if they had a heavy bleed, and just feeling better. One of the key things is that if you're going to do that, is getting the placenta in the fridge, you know, about within 3 hours, roughly, after the birth. And I have heard, I do know that there's some midwives that this is home birth midwives that will get midwives to eat the women to eat some of their placenta. I haven't really seen that, but so I can't cite the study, but a midwife in England has explained that sniffing or smelling the baby's head stimulates more oxytocin in the mother than attempting to breastfeed in panic. That's what Mary said. And yes, Michelle O'Dent talks about that. And I always say to people, because he really believes that people should smell their placenta as well. And so I know that I will often say to women, not necessarily home birth women, because you've already talked about that, but if I'm working in a hospital, I might show that, do you want to see your placenta? Not necessarily, but so it's near her, so she gets the smell of it anyway. And that's something that I went to a lecture of Michelle. I was lucky enough to, when I was a student, go to a lecture from Michelle O'Dent, and he definitely believed that, and I do definitely. So that's really interesting. That might be where he did that, Mary. Hi, it's Patricia here. Just wondering what drugs can be ordered by private practice midwives apart from syntocinon. You should be able to access. Well, depending on the state you're in, because different states have different legislation around drugs, the drugs and poisons legislation. In Queensland, midwives can order any S3, 4 or 8 to the scope of their practice. So certainly managing a PPH and understanding the medication manager PPH was within their scope of practice. So they should be able to access those, the rest of those medications, such as misoprostol. Any tips of PPHs before the placenta? I think, Rose, if it's before the placenta, number one is to get the placenta out. And if it was a life or death emergency, you might need to do, and I've done it once in a small rural hospital under the guidance of a GP, where we did a manual removal. But you would go from, you would switch from physiologic management of third stage to, you would give the oxytocin, and then you would do a control cord traction and birth the placenta, and then continue to go down the medication management. I hope that answered that question enough. What do we do in my place of work in Honduras when we have a PPH we apply? Okay, what we do in my place. Edelyn, you're saying that's what you do? Murtigen, I'm not sure what Murtigen is. So someone from Honduras as well, wow. Great refresh, Belinda. We just how important it is to make the birth environment continues to be optimal for the hormonal physiology of birth for a few hours after. Absolutely. Darkness, quietness, all those things are so important. We have to talk to families about this too. Keep lights low, woman warm, a baby on mum's chest, no calls or visitors before placental birth. Absolutely. Yep. Never, don't crack that champagne until that placenta's out. Is Murtigen a form of oxytocin, Edelyn? You're welcome to take yourself off mute. Okay. Lovely. Well, does anyone have any, if you suspected a morbidly adhered placenta, wouldn't deliver by, would you try biomanual while transferring? That's a really, really good question. I think in that, you probably would. You'd do anything. I mean, because you're trying to save her life. And obviously, if it's not coming away, you're not going to be able to keep pulling on it because you're just going to rupture a uterus as well. I'm happy for anyone to jump on that because I'm just guessing. But I would imagine that you would try bimanual, maybe. I don't know. It is a worry. It is a worry. There is increased accretions. And of course, we know, well, certainly my home birth practice, we had majority of the women I cared for were women who had a traumatic previous birth and ended up as cesarean section. So Mary has said, remember that it is physiological for the woman's uterus to go off the boil while the body replenishes and reorganizes its muscle contracting electrolytes, like the old adage, don't fiddle with the fundus. If the uterus is not yet separated, she won't bleed. Yes, absolutely. Good point. Yeah, so you're talking about, Mary, I guess, not rushing the birth of that placenta, because I do see that. I see that all the time in hospital. It's awful. It's any wonder we get so many PPHs in hospitals, that rushing. Well, it's great to see everyone. We've had 43 people. How awesome is that? Gallery. Just having a quick peek. Know a few names. Just really lovely. If anyone wants to put into the chat anything else they might like us to do, any more kind of webinars and thank you, Alison and Anita and Jay. Suturing at home. I'd have to rope Julie into that, I reckon, Hillary, or you. Suturing. How would we do this? So just I guess a discussion around the suturing, just the practicalities of how you would manage that at home, I guess. Shoulder recess, managing shoulder. Yeah, they're the two that I've touched wood. I've had one PPH, and that was managed quite well. But I have had to resus a few babies and deal with shoulder dystocia at home. So I'd be more than happy to do that sort of thing. Thank you, Cassie. Is this South Australia, Cassie? Neonatal resus is home with minimal equipment. Yep, I'm hearing you, so I think we'll do that. Oh, Joe, that's a good one. So I'll just so people are saying suturing, neonatal resus, managing shoulder dystocia, knowing the home birth environment. Yes, thank you. Thank you. Neonatal resuscitation at home with minimal equipment, suturing practice. Joe, do you have specific timeframes around transfer when the placenta remains in situ but not bleeding or symptomatic? Curious to know what others do. That's a really tricky one. I had a woman home and she was she was fine, and we tried, I didn't do. She'd had a previous. What did she have? She had a previous PPH, I think. So I chose not to do active management on her. I was tempted, but I didn't want to. She was quite a big woman. She was home for around 3 hours, and then we ended up going in, and that the horrendous thing about that was the registrar came in, and of course they treated us all like rubbish because we're, come from home and therefore we were all dangerous people. And he just literally, without putting an IV in her, without giving her syntocin on or anything, just literally did controlled cord traction without even telling her he was about to do it. And then walked out, and it's like, oh my God, like it's so. I kind of wish I had done an active management on her, but I'm not. I did the right thing. I got her into hospital because if she was going to, she was someone that I thought was at risk of a PPH because I didn't want to mess with her too much at home. So, and I've heard of other home birth midwives that it's been, even longer. I'm not. I don't know if anyone else wants to jump in with what they do with the how long before you transfer someone if they're asymptomatic. Nahona, thank you, from a first-year midwifery student in Christchurch, New Zealand. Fiona, facilitating decision-making, informed consent when working with other members of the health team. That is a very interesting one. It's certainly my last round, and Hilary, who's here as my midwife wife. We had a significant number of really traumatized women that were kind of, and it's one of the things I bang on about all the time. A lot of women are birthing at home, not because they actually want a home birth, but they just don't want a hospital birth. And so these are women that have had a traumatic birth and so are considered very high risk. So, the working collaboratively with health services and with the whole way people see you as being dangerous because you're supporting these women, but what you're doing is you're supporting them, and they're the ones that go, okay, now I know I need to go into hospital, and they make that decision, and it's a part of their recovery. And so decision making and informed consent it's a really tricky one. Rowena, suturing practical, maybe collaborate with Griffith. It's hard to get onto these courses. That's very true. And I'm happy to talk with Griffith. I'm doing some marking for them at the moment. That was really helpful. Do we get some sort of certificate for CPD hours? Ebony?
Yes, I replied to Melanie. Yes,
good.
if you're a QNMU member, you'll receive an email after this webinar to a link to download your certificate.
Beautiful. Melanie, supporting physiological birth to maintain the integrity of the hormonal cocktail that supports physiology. Yes, that's my favourite. Let's write down these ideas. So Hilary, 4 hours would feel reasonable. I've heard as long as 6 hours. So that's for waiting to transfer. Jade, estimation of blood loss in water. My birth center team obtained expired blood from a hospital and added it to a filled birth pool. Started at 100 mils and increased to the amount in increments. We took photographs at each increment and laminated these for use. Obviously, this depends on the water volume in individual birth pools. Thank you, iPhone. I know I've seen them. Maybe when I was at Flinders, we used to teach students and we had the laminated ones as well. I don't know, but yeah, I think I have heard the saying if you can't see the bath plug anymore, but yeah, like you said, it depends on how big the bath is, really. Rowena, info on endorsement, working as private midwife, documentation, legality, certification with the hospital's inclusion, exclusion. So this would be great for anyone thinking about moving into private or even public home birth practice if it ever gets going in Queensland. Well, hopefully it will get going soon. And that's a good one, Rowena. A lot of people, I think it would be really good if we had some sort of course about all that stuff about being in private practice. Queensland's got a lot of midwives that have got admitting rights to hospitals, so we have got a lot of people with the expertise and the skills out there. Joe, it's tricky because what feels reasonable to those at the home birth is not considered reasonable at the healthcare facility. Maintaining that collaborative arrangement is tricky. I absolutely agree. This woman that I transferred in, they decided, because her placenta had been in situ for over 4 hours, that the baby was at risk of an infection, and they scared her into letting the baby have antibiotics. And when the bloods came back as normal, then they stopped the antibiotics, and she was devastated. But they literally said to her, "Your baby's at risk of dying," which I see them using that in hospitals more and more, and it's shocking. And there was nothing wrong with that baby. It's just that punishment that sometimes happens. Emma, I found that it is very common in an unrushed physiological birth for physiological third stage to occur at 1.5 to 2 hours post-birth. Think of all the women we've rushed into active management based on timeframes. Absolutely. What if you're not a QME member? Are you meaning QNMU? So Queensland Nursing and Midwifery Union?
I'm guessing that she's referring to the certificates. I just replied to her. So if you're not a QNMU member at the moment, please email the events team at events@qnmu.org.au.
Thanks, Ebony. And if you're not a member, join us if you're in Queensland, or join your union wherever you are. Edlin, thank you very much. Hope to be in the next webinar. Beautiful. Julie, thank you for the webinar. Very informative. Rowena, it would be awesome, even with just a Q&A with some of our awesome experienced PPMs. It's so good. We don't get together enough, I think, and just share our different expertise, because we're all different. Yes, it is awful, Joe. Had a bad run for a while there in South Australia. Sometimes you have really great runs. Like I had one woman I transferred in, and we knew that baby wasn't going to birth vaginally, but she needed to figure that out for herself. And the baby was fine. She was fine. And when we went in, the staff were like, "Okay, what does she need?" I said, she needs a cesarean section. They said, "So you don't want her to have Synto? She doesn't need Synto or anything like that?" I'm like, "No, her labouring has been fine. She's just, 4 foot nothing, and she's got a big baby on board." And not that, and I know being short doesn't mean that you can't birth vaginally, but she'd already had a cesarean section for a large baby, and so they were wonderful to us. They were just like, "Yep, no worries," and put the monitor on her, made sure the baby was okay, and then she went for a cesarean section, all in the way that she worked for her. So it's not always bad, but sometimes it can be. Fiona's septic calculator being introduced in neonatal units now to hopefully prevent this type of experience. Oh, that's so good. I so hope that, because the amount of babies we give antibiotics to is just a bit over the top. So it's just after 11. Thank you so much, everyone, for being involved, and it's been really, really good. And really, I was a bit nervous about presenting home birth stuff to midwives, but if everyone's keen, I'm more than happy to do it again, and we'll certainly let you know. Thanks, Hilary. Good to see you. See your name. And everyone, of course.